Hello, everyone, and thanks for joining us for this Part B Neurology Common Rejections and Denials webinar. This webinar is designed for those who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Moko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your host today, and assisting me with some technical issues is my friend and colleague, Bailey Lawson. We include this disclaimer in all our education, and we do so to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws and regulations and rulings will always prevail. We will provide responses to questions based on the facts that are given. And just a final reminder before we get started here that CMS prohibits recording of this presentation for profit-making purposes. We are recording this webinar and we will post it as an encore presentation. You can stay informed about new postings of the latest recordings in our education news that we publish weekly on Wednesday. This is a copyright notice that we provide for the American Medical Association. Your continued participation in this webinar infers that you agree to the terms of this copyright notice. Should you not agree to acknowledge this copyright notice, you may disconnect now from this webinar. Here is the agenda for today. I have a lot of information that I'll be covering today, but for today's event, what we're going to do and what we advertised that we were going to do is focus on data for those claims submitted to WPS by specialty type 13 or neurology providers. So the data that I'm going to discuss today is specific only to specialty type 13. However, at the beginning of my presentation, when I explain the differences between rejections and denials and provide other information, that's really applicable to all providers, but the data is indeed pulled specifically only specialty 13 claims that we're talking about. So I'm going to provide details on common rejections and denials, and I will include while I'm speaking ways to fix or avoid both of these. And of course, there's just a lot of resources provided in this particular presentation. I'm going to try to find time to share a couple of those with you by way of demonstration. But please know that all of these resources that I'm talking about or touching upon are hyperlinked within your webinar materials. That means if you have an electronic version, you should be able to click on the link and open up that particular resource. Or you could simply copy the link and paste it into your internet browser. Finally, if you have questions, I'll try to answer them as time permits. Otherwise, I will follow up. Sorry about that, folks. I took a drink of water and got a coughing jag. I'll follow up with questions and answers following today's event. Once again, folks, my apologies. Let's get started here. Now, to fully understand rejections and denials, it's important to recognize that a claim has a path it takes during processing, and we refer to this as the life of a claim. Excuse me. This is a simplified graphic on how a claim gets into our system. The provider or supplier renders the service, submits the claim, but the system might reject that claim or the entire batch. And when this occurs, we generate and send a 277 or 999 report. This slide describes that in a little bit more detail. Most providers submit claims electronically. I apologize, folks. This slide describes claim submission in more detail. Most providers submit claims electronically. Very few have an exception to submit claims on paper. There's actually a law that prohibits us from making payment on paper claims unless the provider has an exception to do so. Now, to confirm claim receipt, providers should use the 999 report. Use the 277 report for more specific information. Our Electronic Data Interchange, or EDI staff, created the Medicare 276-277 Companion Guide, and this is a guide that helps clarify and further define data content requirements for an electronic claim. Now, based on both reports, you will know if the claim is rejected and if you need to correct and submit a new claim or a new claim batch. This is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. This slide shows a slide-by-slide comparison of a claim rejection as opposed to a claim denial. And these are really very different things. I think a lot of people use these interchangeably when they're really very different things that happen to a claim. If you look on the left side of this particular slide, you will see a rejection, a list of items for rejected claims. We describe these as unprocessable, and these are actually claims that are returned on the front end. They are never adjudicated, so they're never really processed. The reason for that rejection is because something's invalid or a bit off, something's missing, something's incorrect. It just doesn't make sense. So the claim is invalid and it's kind of kicked out of the system on the front end. Because of this, because that claim is never really adjudicated, there are no appeal rights. What you need to do is resubmit the service, fix it and resubmit it. Now, on your remittance advice, you will see an MA130 and a CO16 code for on that remittance advice. And this means that the patient's not liable. You can't charge the patient for that item or service until you fix it and resubmit it and Medicare makes a claim determination. Denials, on the other end, are actually adjudicated, and the reason we deny claims could be for a number of reasons, but these fail to meet payment criteria, and this is based quite often on laws or what we call statutory requirements. Sometimes the service doesn't meet Medicare's medical necessity parameters or criteria, and this would include any frequency or utilization guidelines. In those cases, if something's denied as not medically necessary or denied due to frequency, those are those situations where you would need to consider presenting your patient with that advance notice or advance notice of non-coverage for the beneficiary, or the ABN, as we used to call it. Also, claims are denied sometimes due to eligibility. Sometimes it's the provider that's not eligible, or it could be that the patient is not eligible on that particular date of service to receive Medicare payment, or coverage, I should say. An MA01 code on the claim, or on the remittance advice that should say, provides appeal rights. Most situations when claims are denied will allow for an appeal right. There's very few exceptions where you can't request an appeal. And of course, patient liability is to be determined for denied services. So here then is a graphic, a simple graphic that shows that path for a processed claim. The service is provided, the claim is submitted, and Medicare determines either to pay the service or deny the service. And then, of course, that remittance advice is generated. Let's talk about that remittance advice just for a minute. Most providers do receive an electronic remittance advice. Sometimes we call it the RA. Sometimes you'll hear people call it the remit or the notice. What we're talking about here is the remittance advice, and there are two different formats. As I mentioned, most people are getting that electronic remittance advice as opposed to the standard paper remittance or SPR. That ERA includes details about the transfer of funds and payment processing from the payer to the healthcare provider's bank. And depending on how the claim is processed, it may also include information about adjustments that are made to the claim or, of course, denials. It could also include information about something that's missing. Sometimes it provides notice about refunds, and sometimes it provides notice about offsets. So very, very valuable, the information on the remittance advice. On that RA, you will see many, many codes. These provide information about the claim, and claim adjustment reason codes, or CARCs, sometimes we call those CARCs, explain why a claim paid different than what was billed, and remittance advice remark codes, or RARCs, we call those RARCs, provide more details about an adjustment that's described by the claim adjustment reason code. Another type of code that appears on the RA is a group code. These convey the financial responsibility for the unpaid portion of the claim balance, and a CO group code reflects a contractual obligation. The provider is liable and you can't bill the patient. For rejected claims or unprocessable claims, you're going to see that CO group code on the remittance advice, CO16 to be specific. A PR group code, on the other hand, means that the patient is financially responsible. Now you can find code lists on the Washington Publishing Company's website. That contractor maintains those codes for CMS. You can find the code lists on their website, and I've included links to those resources for you here on this slide. Now we do understand that some of those codes may be cryptic and some of them may seem to be out of date. For example, this company, not WPS, uses some acronyms that are outdated. For example, HICN, Health Insurance Claim Number. We don't call it that anymore. It's not the Health Insurance Claim Number, it's now the MBI. Please understand that these that I'm going to be presenting today do include those outdated acronyms, but I am giving you the information exactly as it appears on the reports that we run. During one of my last sessions, someone mentioned that I was giving out acronyms that were outdated. And while I did discuss them, I also explained that these outdated acronyms are being used in those messages on the remittance advice. So that's why my presentation includes those. I want you to be able to connect those, excuse me, those exact messages on the remit notice with what I'm talking about today. We can't change any of those codes at WPS GHA. However, if you go out to this website, this Washington Publishing Company's website, there is an address to which you can send suggestions or comments. So if you'd like to do that, feel free to do so. All right, let's get rolling here again. After reviewing your remittance advice, you're going to have to choose what action you need to take. Do you need to fix that claim and resubmit it? Can you correct it? There is a process that allows you to correct some minor omissions or clerical errors. Or do you need to resubmit or request an appeal? So for an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim to Medicare. If the claim or a claim line denied, there might be multiple actions to choose from. You may be able to simply resubmit the service. You might also be able to use a process that we call the clerical error reopening. CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. I'll talk more about that process later in this webinar. Another action to consider is requesting an appeal. The remittance advice will provide appeal rights. I'll discuss appeals also later in this webinar. Registered users can use our transactional portal to render a clerical error reopening, or you can request an appeal by using that self-service tool. These really do offer the most efficiencies, and we do include a link to our portal user manual on our website. It includes illustrations and step-by-step instructions on how to use these portal features. So more on that later. If you're looking for more information about the remittance advice, we could actually probably spend 60 minutes talking about the RA itself. I've included these two resources for you. These are some resources on CMS's website that provides more information about the remittance advice. Next, I want to talk, if I can talk, folks, that is, about when you need to correct or appeal the MAC's decision to pay or deny a claim. And when I say MAC, for any of you that are not familiar with that particular acronym, it stands for Medicare Administrative Contractor. WPS is the MAC for Jurisdiction 5, Iowa, Kansas, Missouri, and Nebraska providers, and Jurisdiction 8, Indiana and Michigan providers. And of course, J5 also includes our national Part A provider contracts. I talked a little bit earlier about that clerical error reopening process and told you that I would share more details. This is the process to correct human or mechanical errors, and clerical errors or minor errors are limited to errors in form and content. They are not omissions such as failing to bill for certain items or services. Your handout includes a link to the resource titled How to Correct, or how to request rather, a clerical error reopening. That particular resource is a great one if you're using this process, if you're doing it, self-service, or if you're calling in for this to be done. There is examples of clerical error submissions that are appropriate, such as mathematical or computational mistakes, perhaps inaccurate claim entry. Maybe it was a computer error that caused this. At any rate, that article provides for you a list of what is appropriate, and then some of those situations where you cannot use this process to fix your claim. That would include, for example, provider enrollment issues or wrong payee situations. Maybe it's a situation where the claim requires analysis of documentation. Those cannot be done as clerical error reopenings. You can do this self-service, as I mentioned, by using our transactional portal, or you can request a clerical error reopening via telephone or fax. All right, here's that more information I said I would provide for appeals. There are 5 levels of appeal, time limits for submitting and for completing an appeal, and monetary thresholds do apply for certain levels. Of course, the time limits for submitting and completing these apply to every level, but the monetary thresholds apply only to levels 3 and 5. These monetary thresholds are referred to as the amount in controversy, and these apply only to levels 3 and 5, as I mentioned, but based on law, these monetary amounts can change from year to year. You can check out a resource on our website called How to Appeal a Claim Determination. This is a great resource that provides details about who can request an appeal. The beneficiary or their representative can request an appeal for any service processed for them, and providers and suppliers, for the most part, can appeal services for which they accept assignment. But there are a couple of exceptions. For unassigned claims, providers and suppliers may act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement, and one example of this would be the CMS 1696 appointment of representative. And providers and suppliers can also request a redetermination on unassigned claims for a couple of situations. One is if the service is denied as not reasonable and necessary, or when the provider or supplier billed in excess of the limiting charge. And of course, in that case, if they billed in excess of the limiting charge, any amounts collected from the beneficiary over the amounts that they're liable for would need to be refunded. Here are some appeals resources. Again, this is a topic we could easily spend 60 minutes on. There is that how to appeal a claim determination. This is a resource on our website. And then the second link there that I've listed is one of my personal favorites that I like to provide for people when I'm talking to them about appeals. And this is actually a flow chart that appears on the CMS website. The title of it is Fee-for-Service Appeals Process Flowchart. This is a real quick at-a-glance document where you can see all 5 levels of appeal. You can also see a side-by-side comparison of the standard appeals process versus the expedited appeals process. And the standard process is for parts A and B, and the expedited process applies for some Part A only appeals. So it doesn't apply to Part B. Some of you I know prepare and submit claims for both Part A and B, so that might be a helpful resource for you because it has that side-by-side comparison. But really a great document. I love it because it everything just shows there really in a graphic, and I like to look at visual things. So those time frames are there, those amounts in controversy, those dollar thresholds that you need to meet for levels 3 and 5. And I neglected to mention earlier that if you have denials and you're not meeting that threshold, you can combine like denials. Doesn't have to be the same beneficiary, but you can combine like denials in order to meet that threshold, in order to meet the amount in controversy for levels 3 and levels 5. All right, folks, so here, this is that portion of this presentation that will reveal the most common rejections and denials for Specialty 13, which is neurology. Now, the data that I'm sharing today is specific to Specialty 13 submitted claims. When I mined the data or asked, requested a report, if you will, for rejections and denials, I placed Specialty 13 in as one of the slicers, as they call it, to get the data. I requested all states in jurisdiction 5 and 8 combined, so that means you'll see data for Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. Now, this data dashboard that we use is a tool that was created by our Insight team. That's our data informatics team at WPS GHA. They created this so people like me and like Bailey and all of my teammates can go out, put the various slicers in. Do we want to see one state only? Do we want to see a county? Do we want to see only Part A claims? Do we want Part B claims? Do we want both? Do we want all states or one state or 3 states? So we can put these various slicers in, as they call them, and then it will immediately bring back that data for us. And I neglected to mention we can differentiate between rejections and denials. We have several other dashboards like this that we use, and it is in CMS's Internet-only manual that they say that we in outreach have to base our education on rejections and denials. It's just one of those expectations from CMS that we need to use this data in order to present education for our providers. So that's why we're doing this today. I'm actually running a series where I'm pulling data for each of all of the specialties and presenting it back to providers so that you recognize if those are the most commonly rejected reasons or codes. You can take a look at that same information within your organization. Look at the remits. Are they the same reasons? Look at your claims. Are they the same codes that you are submitting? And then you can either fix those rejections and denials or avoid them altogether, and that's really our goal. So the data I'm presenting is Specialty Specialty 13 all states. The claim submission dates that I pulled are March 1 of 2024 through May 31 of 2024. We can pull in 3-month date increments of claims or 3 months worth of data at a time. This data was last refreshed on June 5th. That was shortly before I had to have this presentation finalized and through review and approval in order to give you the handout materials you have today. So what that means, folks, is that any claims submitted by Specialty 13 providers for those submission dates after June 5th of 2024 won't be included in this data. Here then is my reveal of the most common rejections, and this is by reason code. And this, folks, is where I want to point out to you that right there on this slide you see an acronym that's outdated. HCFA, I know that it's outdated, but the reason I'm sharing it with you is because this is the way this reason code prints out in the data runs that we pull, and we can't change it because those reasons are maintained by another contractor. So first of all, claim lacks information needed for adjudication. 1,453 rejections. I'm talking about rejections now, and remember they're very different than denials for that 3-month time for claim submissions for Specialty 13. Now that could be any of a number of things. You're going to need to check your claim over to see that you've included all of the information that's required on a claim. We do have claim form instructions in the internet only manual that goes step by step, you know, item 1, item 2, item 3, and it tells you whether it's a required element or situational, and meaning that it depends on something else that's on the claim, whether you need to complete that item. Typically, you're going to see more than one reason on a claim, and that will help you better know what it is that your claim is lacking. Missing, incomplete, invalid ordering provider primary identifier, 381 rejections. Most of these rejection reasons are really quite self-explanatory, so you're going to know what you need to do. If you're missing or you added an incomplete or invalid ordering primary identifier, what are you going to need to do? You're going to need to fix it and resubmit it. The authorization number is missing, invalid, or does not apply. So that means that for the service that was billed, you need to look at the claim, you know, or the remittance advice to see what service was billed. And for that particular item or service, there is the expectation that an authorization number would need to be entered on the claim. If it's missing or invalid or perhaps transposed when it was entered, it will reject. You know, maybe the authorization number is there, but it doesn't apply at all, so your claim rejected. Another reason you need to compare the information on your claim to what the remittance notice is telling you and fix it, resubmit it, and then you can be receiving payment from Medicare. Claim must be submitted to RRB. RRB is how that reason code prints out, so that's why I've included this acronym on the claim, or on this slide. This stands for Railroad Board, Railroad Retirement Board specifically. That means that instead of submitting that claim to WPS, you need to submit it to the railroad contractor, the railroad MAC, and that is Palmetto GBA. Next reason for rejection, field 11 of the HCFA 1500, I know that's the CMS 1500 claim now, must be completed. Over 1800 rejections, I almost said denial. And look at that first word in this reason that prints out on the remittance advice. It says denied, but it's really a rejected claim. Again, something out of WPS's hands. We can't change that reason code. Only the Washington Publishing Company can do that. Field 11 on the HCFA 1500 is the field where you have to tell Medicare, is there another insurance that's primary to Medicare? That field can't be left blank. So if you know there's another insurance primary to Medicare, you're going to say yes, and you're going to add the additional information on the claim and the additional fields or items, if you will, that tells us who it is that's primary to Medicare. If there is none, you need to put none in this field or in this box or item on the claim form. You can't leave it blank. A lot of claims reject for that reason. The next one, the hospital should bill Medicare Part A for this service. That means it needs to be billed not on the CMS 1500 claim form, but it needs to be submitted on another claim form type because the hospital should bill for that. It's a facility charge. Missing, incomplete, invalid name, strength, or dosage of drug. And this is going to make more sense when I show you the common rejected codes here in just a minute. Typically, this means that you billed for a drug that requires that you identify on the claim the strength and the dosage of the drug, or the name of it. 148 rejections. The next two say denied, but we're talking rejections here. You need to fix it, resubmit it. Rendering physician number is invalid or missing. Submit a new claim. That one's self-explanatory. Your rendering physician number needs to be entered on the claim. Invalid or missing modifier is the next common denial, or excuse me, I need to correct myself, rejection, 127. We have modifier fact sheets on our website that provide for you the reasons for using a particular modifier, or what I should say is appropriate use, and it also identifies inappropriate use. So for this, it means that you entered an invalid modifier or it's missing one that's required. So you need to review that claim, determine if you need to add that modifier or if you used the wrong one. Maybe it was transposed when it was entered. Anyway, this is invalid or missing modifier, and it is definitely a rejection, not a denial. The next one, the claim was denied, and it wasn't denied. It was rejected because information submitted was incomplete. That might mean that you submitted documentation to support the service you billed, but the documentation that was requested is incomplete. Here then is a reveal of the common rejections by code, by HCPCS or CPT code. I want to just talk about a few and then give you a further breakdown, and we can give you a further breakdown, but for that, it would take more than 60 minutes. So I'm going to quickly tell you reasons why these are denying. These are, in fact, I just did. I just gave you the top or the most common rejection reasons. Now, these are the codes that are rejecting. So J0585, I can tell you that this one is rejecting missing, incomplete, invalid name and strength or dosage of drug. The authorization number is missing, invalid, or does not apply. And this claim was denied because information received was incomplete. So this, folks, is a situation that for that Botox injection, there is documentation required, and we either didn't get it, or you didn't put the authorization number that's required on the claim, or we didn't receive on the claim the name, strength, or dosage of the drug. Well, we know the name of it since it's a Botox rejection, but that would mean that the information's missing or complete. That G0463 you see there is the hospital outpatient clinic visit for assessment and manage of the patient. This is that facility charge, and this is why your claims are rejecting for this specialty, because the hospital should bill Medicare Part A for this service. Instead, it was billed to Part B, so it's rejecting. 95886, that's the EMG. This is denying, or excuse me, rejecting because missing, incomplete, invalid ordering provider on the claim. This would include the ordering provider's identifier. If it's not there, your claim is going to reject. That means the claim lacks information needed for adjudication. So again, this would be a situation where there would be two reasons. The related service was not on the claim. You would need to look to the policy and see the coding and billing guides for this service and make certain that this service is being billed only when the related service is also being billed. Another reason this is being rejected is that the claim must be submitted to the Railroad Retirement Board, not to WPSGHA. You see a number of E&M codes on there. Many of them are rejecting because the claim lacks information needed for adjudication. Many are being rejected because the claim needs to be submitted to the Railroad Board. There's a couple of them that hit because the Field 11 of the HCFA 1500, actually the CMS 1500 must be completed and wasn't. This 99215 is rejected because missing, incomplete, or invalid ordering from a primary identifier, authorization numbers missing. These are all kind of similar, and I did talk about the reasons on the previous two, but this is a situation, folks, where we can do a deeper dive into each of these codes to tell you specifically why they are rejecting. I mean, I ran through the list here really quickly and actually did present the 10 most common reasons on the two preceding slides. But if you want a deeper dive, this would be a situation where you might want to include on that brief survey that you're going to fill out that you want a deeper dive into rejections by code. We're hitting on the top reasons today. I threw in these codes just to provide you with a good idea of what we can see on these reports and the information we could go digging up if we want to. I just talked about reasons. I want to talk now about denials. Collection of fee-for-service during periods of managed care. This one's a little cryptic, and I'm not going to lie. A lot of these reason codes that spit out, for lack of better words, on your remittance advice, or print out on your remittance advice, that's better, are a little cryptic. So I went to our systems folks and I had to ask them, is this really what I think it is? Does this mean that the beneficiary has elected Medicare Advantage? And that's exactly right. For those situations, 2,474 denials because that claim should have went to Medicare Part C, not Part B, not your MAC. It needs to go to the Medicare Advantage plan. We have some good education out in our both on our website and on our YouTube channel that talks about managed care or Medicare Part C. Those claims need to go to the plan. Now, for the next particular denial reason, I've kind of pushed two together because they're duplicate charges. Actually, three. Just yesterday, my colleague Tom Ryan held a webinar, 1-hour webinar that talked about duplicate charges and how to avoid them. You can have a message that says this is a duplicate charge. You might get a message that says duplicate charge paid on such and such a day on such and such a claim. Or you can get another type of duplicate denial that says duplicate charge of claim such and such now being processed. So that means there's a duplicate currently in the system processing against the one that's being processed here, or the one that's being denied. So there's all different reasons for duplicate charges, duplicate denials. For over 20 years, I've been in outreach and education, and duplicate charges or duplicate denials continues to be one of the most popular or most common reasons for denial. Tom's webinar really delved into waiting for that claim, waiting at least 30 days for the claim to be processed. Even though the payment floor for an electronic claim is 15, you should wait the full 30 days and then check to make certain that that claim hasn't already been processed before submitting a new one. Sometimes billing services just have a cycle that they use. If you're doing that, you need to stop. Sometimes billing services do that. Ask them to stop. We need to avoid these duplicate charges. They cost you, the provider, and Medicare a lot of money. Not medically necessary. 704 denials in that 3-month period. This would relate to a policy. So you need to look at that item or service you billed and go look at the policy to see the coverage parameters for it. Medicare deemed these services not medically necessary, and policies equal edits. There's edits in the system that will check to see if all of that information on the claim justifies the payment of that claim. Social Security Act says that no payment will be made for any item or service that's not medically necessary. That's the overarching criteria for Medicare payment. It needs to be medically necessary. If it doesn't meet the coverage criteria in the policy or in the billing and coding articles, it wasn't entered correctly, then the service isn't payable. And I'm going to show you a quick look of how you can look to see if an item or service is included in a WPS policy or local policy. There's also here under this code lookup tool, the availability for you to check to see if there's a national coverage determination. That's NCD, or local coverage determination and article. And I'm going to look up local coverage determination and article, and I'm going to choose this code because I knew it showed up on the rejections report, and search. This is on the home page of our website, folks. And sure enough, for this particular code, let's say this code denied on your remittance advice is not medically necessary. You could come here and it would provide you with a link to the local coverage determination or a link to the coding and billing article. Your claim denied is not medically necessary. You need to look at these policies, look at the information in them to see if you correctly entered information on your claim in order for us or the computer logic to know that you met those payment criteria or those payment parameters. Now, one thing I'm going to tell you is that we did not advertise that we were going to delve into policy during today's webinar. I'm going to tell you what the most common reasons are and where you can find help to avoid them in the future or fix them. My colleague is planning a series of LCD or policy related education webinars. If you need help with neurology policies or those services that would have or be governed by a local coverage determination that WPS has published, when you fill out that survey, ask them or put on there things that you're looking for in the future would be such an education on, and then tell us specifically which policy. We're going to look at the survey feedback to make certain, first of all, that the people that are telling us what they need are that we're looking at and listening to you. That's what the survey is all about. So if there's a particular policy, for example, this one is L34594. That's the ID for the nerve conduction studies and electromyography services. Let us know you want education on that policy. Okay. All right, not medically necessary, not covered when performed, referred, or ordered by this provider. Take a look. Who was the performing, referring, or ordering provider, and why is their services not covered? This might be a situation where you need to contact provider enrollment to see if that particular provider was eligible on that day, or perhaps it is a service that's not covered or only covered when certain types of providers bill for it. Okay, that might be in a policy or other information that's published either on our website or CMS's website. Sorry, I hit my scroll button here. Denied service units of denied service or units of service are exceeded. This is what we're talking about here, are those denials that pertain to National Correct Coding Initiative medically unlikely edits, or MUEs. Service denied because the units were over the MUE for that item or service. Some services have a limit as to the number of units that can be billed on same day by same provider for same patient during same encounter. Not all MUEs are published. Most of them are. But this would be a situation where you need to take a look at your documentation to see, was it medically necessary for you to exceed that MUE? And if so, you should request your appeal and provide that documentation. Point right to where it is in that documentation that says or that proves that the additional units of service should be paid for by Medicare. EGHP, claim must be sent to the EGHP, that's Employer Group Health Plan, or the Large Group Health Plan, the LGHP first. These are Medicare's secondary payer situations where another insurance is primary to Medicare. You need to send the claim there first. Time limit, whoops. Time limit for filing your event has expired, or filing your event, your claim has expired. We have a great article on our website. I'm just going to search for it this way. Timely filing of claims. This explains, I'm on a J8 MAC Part B website. You can also look at J5. This talks about timely filing of claims, and this is one of the links in your resources that are coming up next. Talks about timely filing on claims. Claims based on timely filing limit do not have appeal rights. I mentioned that earlier. Most claims have appeal rights. Some are accepted. Here is what I want to point out to you, because this is the thing that most often affects our providers. This speaks to providers who ask us to reopen claims denied for timely filing when another insurer recouped their previous payment, maybe another third party or another insurer. Uh, in the IOM, and we have a link to it here, it specifically states that CMS doesn't accept errors caused by incorrect third-party payment as justification for not submitting claims timely. This italicized language here is exactly where it says that. This is excerpted from Chapter 34 of CMS Publication 100-04. That's the Claims Processing Manual. So that's where it says just because the other insurance comes back and takes money back doesn't mean that Medicare is going to pay beyond the timely filing limit. Here are some potential reasons where we could extend the late filing limit, and this tells you how to file the waiver to our claims manager to request a waiver of that timely filing. Of course, this is Iowa, Kansas, Missouri, and Nebraska, because if you look up here, I'm the J5 MAC Part B website. If you're on the J8 MAC Part B website, it will show Indiana and Michigan. All right. Medicare will not pay for this service for this condition. That's, well, I'm so sorry, policy related. Look at the coding and billing guidelines and look for the payable diagnoses for that item or service. It's service, I should say, not item. That's where you're going to find that list of payable diagnoses in the coding and billing guidelines. If your documentation doesn't support one of those, we're not going to be able to pay for it. And lastly, can only pay for one initial visit per specialty. And you'll see that when I move to the next slide and notice that some of the codes, specifically the 99205, that's an initial visit code, we can only pay one initial visit per specialty per group. So that's a reason why this particular code is rejecting. Other reasons these codes are rejecting, I just talked about them on the previous two slides, but your Botox is rejecting because the required information wasn't received, or the information was received and the information doesn't support the need for this service. So look to policies. Dupes are a problem for most of these codes. Not medically necessary services affected by the 95886. Duplicates. We get tons of duplicates for this code. And then, of course, Medicare will not pay for this service for this condition. That's the 95886. Lots of duplicate charges here for the E&M services, so watch when you're coding those. Make sure you're waiting that full 30 days before you resubmit a new claim. I'm looking at other reasons I have here. And again, if you want a deeper dive into more reasons why these codes are rejecting or denying, these are the denials on this slide, make certain you let us know when you complete your survey. So I talked a lot about all of the data for Specialty 13 for all 6 of our states. I do want you to know that we can break down by state, by county, by particular code, and we can also look at trending. The reason I'm telling you this is that some of you may belong to organizations, societies, associations, and such, and we often get requests to come or to send a speaker, to an event, let's say in Kalamazoo, Michigan. There's an AAPC, American Academy of Professional Coders group that's sponsoring an event on a certain day. They're asking us to come and talk about rejections and denials. We can actually break down by state, so it's Michigan, by county. We can choose all of the counties that surround Kalamazoo because that's where the people are going to be coming from, and so on and so forth. So I wanted you to be aware of breakdowns, and especially this last one, trending. We can look at data trending easily on these reports that we pulled, and this one was Specialty 13 for those 3 months of submitted claims. We can tell for the 3 months prior how many claims were denied compared to the current 3 months. So look at the change here. We went from 334 denials to 828. That tells us we need to look at data and determine what's going wrong and where do we need to find or how do we need to prioritize what we educate on. We have to use this data. Here's an example, and I chose the limit for filing your claim has expired, no appeal right. In the current 3 months, we had 551 denials, but in the 3 months prior, only 250, and that's still far too many. The difference in the number of claims is 301. The report tells us the percentage change is 120%, and the difference in the claim change, the increase, there shows an arrow up. So there's a visual when we look at these reports. So if the arrows are all pointing up, something's wrong. We want those to point down. Resources and tools. Now there's a lot of information here, and I'm not going to specifically go through all of them because I touched on a lot of them already. But if you're looking for requirements for the claim form, what is it you need to put on the claim form? Here is a link in Chapter 26 to completing and processing the 1500 data set. I want to show you another tool that I have found to be particularly helpful, and I like to point this out and demonstrate it during my presentations. I'm going to the W, and that is the second one there, that crosswalk. If you go to our website homepage and you go under click links over here on the right, choose EDI, which stands for Electronic Data Interchange. Scroll down, choose Medicare. This is where you can find the EDI reports, the electronic claims information, those companion guides I talked about earlier, the 276, 277 companion guide that explains the data elements or the data requirements for our claims. Here's where you find those. But right now what I'm talking about is the crosswalk. So if you're looking in the claims, in the manual, in the IOM for those claims, completing and processing of a claim, let me make this bigger here. You can come out to this crosswalk and look at this document that shows you item, narrative, ANSI version 5010, the loop on the electronic claim, what is the data element description, what's the status, and what's the requirements for the claim form. This shows you, for example, if you enter something in item 11 on a paper claim form, where does it go on an electronic claim form? This is what it shows you right here. This is the information. So this crosswalks the paper claim to an electronic claim. What is very helpful too is this particular column, which is S for status. S means situational. That means the data element must be completed if other conditions exist. If there's an R in that particular status column, like right here, it means that the data element is needed in order to process a claim. If you fail to put that information on the claim in these places, guess what's going to happen? Your claim is going to reject. So this is just another one of those great tools. Lots of tools here and resources. Here is our tool for rejections. We list by remark codes how to correct a rejected claim. So it will give you one of many reason and remark codes. Remember those CARCs and those RARCs I talked about. We list those in this particular article, resource on our website. And then we tell you for each of those reasons how to correct that rejected claim. Similarly, we have a resource for denied claims. And for these, we kind of bundle them up based on the category for the denial. So I told you earlier, duplicate claims, there's a lot of reasons a claim denies for duplicates. So we bundled all of those together, and you can find it. Oops, sorry about that. There in this resource under the duplicate claims, that category. We have a bundling category. We have an entitlement category. I know people struggle with entitlement. CMS has a really good resource on their website. I'm going to show you that in just a little bit, or actually show you where you can find the resource. You know, you can use the self-service tools in order to check what do I want to say, entitlement. So and claim status as well. So all kinds of great tools are available so that you can avoid these types of denials. Here are link to our website. MSP we talked about earlier, so it's here in your resources. Live events or future education. Encore presentations, those are our recordings, folks. LCD and article lookup, I demonstrated today. Our YouTube channel has a lot of great videos out there. There's a lot of playlists that kind of group. So for example, if you're looking for evaluation and management services, we have a playlist for all things E&M. We have a playlist for all things mental health. You know, we have a playlist for other types of education as well. I've included a link here to Medicare Advantage plans because that's one of the rejections or denials that we talked about earlier today. Prior authorization, we get some questions on this. It's really not specific to your specialty necessarily, but I do have a link for it here. This is the link to the modifiers web page. We talked about the modifier fact sheets. I'm going to show you that real quick. I know we're getting close on time here, so I'm speeding up a little bit. I apologize for that. Getting myself set up here. Stick with me. It's just a little slow. Sometimes there's a little bit of lag time. All right, here we go. Coming. There we go. So if you are looking on our website, you can search by modifiers if you want. You'll see all of these results that pop up. You could choose the one you want. This is our modifiers web page. You can also get to this page by going to claims and scrolling down and choosing modifiers. Takes you to the same place. There's 2 clicks. Here are all of those modifier fact sheets that we have available. And for these, I told you we have, for most of them, I'm just going to pick one here, the definition, and then we'll have appropriate uses and inappropriate uses and any other information. Some of these also include ranges of CPT or HCPCS codes for which the modifier is applicable. Timely filing of claims, I demonstrated Freedom of Information Act I've included here so that you can request specific information on rejections and denials for your entity. There is a cost associated with that. Here is a link. It says we want to partner with you. That's our article about partnering for those situations when you want to invite someone to speak at an event. And, you know, we can talk about soup to nuts at those. You need to let us know what you want to hear about. The Medicare Coverage Database is a national searchable depository of all policies, not just WPS policies, but our other MAC policies as well. You can get to national policies, you can get to local policies. If you don't know how to use the database, this is a great educational tool that CMS has published, how to use the Medicare Coverage Database. And I know that we've offered education on that in the past, and one of my colleagues that has it on their docket for very shortly. Evaluation and Management Services Guide is all things E&M that you may want to learn about. That's a CMS product. CMS has published this resource, Billing Medicare for Remote Interruptive Neurophysiology Monitoring. That's that HCPCS code G0453 that needs to be submitted by the hospital. Correct coding initiative edits. We talked about those medically unlikely edits when your service is denied because they're in excess of the MUE. So this is where you can get help and avoid those. Here, folks, is I mentioned to you about the rejections or denials today that are specific to missing ordering or missing referring information. Maybe it's incomplete. Maybe it's invalid. Maybe it's not appropriate. This is that CMS resource that I mentioned to you earlier. Excuse me. It is a huge list of ordering and referring providers. All those providers who are eligible to order and refer services has their identifiers there, so you can make certain that you're entering that information correctly. Here is some great information CMS has published about checking Medicare eligibility. I mentioned a couple minutes ago, I know a lot of you struggle with finding information on eligibility, or you just don't know where to get to it or how to find it, or you know the best ways to get your hands on that information. Here is a Medicare Learning Network, that's MLN, fact sheet that CMS published, recently updated back at, well, not so much anymore. Time is getting away on us. It's July already. September 2023, some great tips and tools for checking eligibility. Here's information on the beneficiary notice initiative. So for those services that you believe Medicare will likely deny as not medically necessary, this is where you find information on what's appropriate to present to your patient and how you need to go about doing that, and the forms you need to use in order to substantiate that advance notice of non-coverage or advanced beneficiary notice was given and it was correct. All right. I should say filled out appropriately. Here's some information in the next two slides, and I'm just going to kind of pop back and forth while I'm talking. Both the WPS GHA portal and the IVR are self-service tools. These can be used to check eligibility. You can use these to find claim status, details about claim denials. More specifically, you're going to find more information. Whoops, I went too far. When you're using the portal, this is our transactional portal. You do need to register to use it. It is a secure site, available 24 hours a day, 7 days a week, just like the IVR, which is that tool that you use your telephone keypad or your voice. There's limited functionality for both of these outside of business hours. And for both of these, we do have resources that tell you how to use them. We have the IVR operating guide, and we also have the portal user manual. If you're looking on any page of the WPS GHA website, and I clicked it close when I pulled this over, I apologize. WPS GHA. If you're here on any page of our website, you could scroll to the bottom and choose the portal user manual right here. Also, top of the page, the portal user manual link is right under the login box. And this is where you would log in to use our secure portal, that transactional portal. All right. Questions and answers. We are kind of out of time here, so I'm going to tell you in a couple minutes how you can submit those questions and answers. If you placed anything into the chat during this presentation, we will answer those questions as well, if we didn't already cover the information. CMS has asked us to provide this information to everyone who attends our education, both this information and the information on the next slide. CMS is teaming up with Neurology Healthcare Solutions to host an annual National Provider Enrollment Conference. You can use this link to find information on the schedule, the description, registration. It's free. You know, you have to pay your own way and your lodging and your food, of course, but it is in San Diego. Times do vary by day. Bailey will put the link to this in the chat. So if you are not one of those people that is involved in provider enrollment activities at your place of business, maybe you are involved in compliance, and CMS is hosting a virtual conference, also free, National Provider Compliance Conference. It's August 7th and 8th from noon to 4 each day Eastern time. And again, Bailey's putting the link for this into the chat box. But if you have the electronic version of the presentation materials, you'll be able just to go over here and click on and see that agenda and registration. I know that for both of these, there are actually speakers from WPS that will be participating. Finally, I just want to share with you that our greatest compliment is when you recommend our education to others. Please help us reach our goal to provide current and effective education for everyone in our jurisdiction by recommending our education to others. I know a lot of you belong to associations, societies, and such. When you're at these meetings, if you could put a bug in people's ear about something you saw on our website or our YouTube videos, we would greatly appreciate that. On behalf of myself and Bailey and the entire provider outreach and education team, I want to thank you for your participation, for hanging in there through those coughing jigs, and for going a little bit long today. We look forward to your survey comments, and we hope to have you join us at future events. You may now disconnect. Thanks, everyone. Have a great day.